Thanks very much, and happy to be with you for this super important topic, if I do say so myself. So it's a pleasure to bring to you the experience I have as TB controller for New Hampshire, and just so many of the same issues that come up again and again. So I want to call them out. Let me turn my video off if you don't mind, because I'll be less distracted by wondering if I'm looking at the right screen. So with that, you see my title slide with the granuloma and my name buried somewhat within that. So it's a pleasure to live and work in New Hampshire, and I have the great advantage of being both in academic infectious diseases at Dartmouth and also in state public health as the deputy state epidemiologist. I have another role that I'd like to disclose to you, and that is as a consultant to the nonprofit Gates Medical Research Institute. My role is for TB treatment response biomarkers since January 2020, a very inauspicious time to sign any professional contract for sure, but it's been a really gratifying role for me that's helped me to know more about diagnostics and biomarkers and the like. But the content of this presentation doesn't relate to any product that I have a commercial interest in at all. So just starting with the historic note, I hope you're here because you want to be, because TB is such a remarkable, impactful disease. It's impactful now, and it's historically impactful. It really drove medical advancements, the invention of the stethoscope, our efforts to visualize bacteria, famously by Robert Koch in 1882, which has given us the World TB Day in March. X-rays were invented in part to track tuberculosis. Again, efforts to more efficiently visualize bacteria were developed late 1800s by Zeal and Nielsen. We'll come back to that. And look at that. In 1908, Dr. Mantoux developed the tuberculin skin test. Boy, how many other diseases are using technologies that are that old? Not many, I'd hazard. So then culture came along, and a huge gap before there was any kind of major advance with regards to culturing, and that was with the liquid culture media systems that we'll talk about. Line probe assays were developed exploiting the development of molecular interrogation to disease. And then in 2010, Cepheid's expert MTB-RIF assay and the IGRAs, the interferon gamma release assays, were developed. So that's a lot of big words in this first slide, and it serves something like an agenda for what we'll do. I've highlighted here that we're going to talk about X-ray, AFB stain, culture in the liquid form, and then we just have to talk about expert in some exuberance. I know you have other tracking that will get you up to speed on IGRAs, and I'll only make a passing reference to those today, trusting the other speaker within this course. So let's align neurons. Let's really put a focus on it by thinking about a very typical case that at least comes to us here at Dartmouth, but also comes through health departments all the time. So no matter where you're sitting, you likely will hear a case similar to this. Yes, it's a very short vignette because I think you'll see the point. In this, imagine a newly arrived refugee who's referred to your clinic for latent tuberculosis infection treatment, abbreviated LTBI going forward as well. And the reason they're referred is because their process for adjustment of status through the civil surgeon process showed a tuberculin skin test of 11 millimeters. You do the typical review of TB symptoms and get a bit of soft signal, and how often this is, right? The patient has some report of inadvertent weight loss, but of course they don't like the US food. They haven't really gotten into the groove of it yet. I don't know, maybe they have some night sweats, but they quickly explain it with the heat doesn't work well and the room is too hot, and here we are in summer now. And in response to the question of, do you have any cough? You get an answer of, well, sure, everybody coughs once in a while. I think I cough because of allergies. I used to be a smoker. People are able to explain symptoms. And so you're not quite sure how to pin your next diagnostic move on this review, but you have some concerns in consideration of latent TB infection treatment. Heightened when on physical exam, there's a bit of a temperature and your exam is not normal in terms of some abnormal lung sounds in the right upper lobe. Of course, before treating for LTBI, I'm sure that maybe just a reminder to mute, and you'll learn quickly I'm easily distracted. So thank you for paying attention to making sure you're muted. So back to that physical exam, in preparation for latent TB infection treatment, of course, there's a chest x-ray. It's abnormal, validating what you heard on physical exam with some right upper lobe fibronodular opacities with volume loss and hilar retraction and right apical pleural thickening. So I know that some of you will not necessarily know how to interpret a report like that, but I'll let you know that it's non-specific. That is, it could mean a lot of different things, but it especially suggests previous disease and scar tissue with healing. So what do you do now? You have this patient before you, positive tuberculin skin test, plus minus on the symptoms, but true abnormality on exam and also on x-ray. So what would you do? I think that these are the kinds of responses that I regularly hear clinicians take. Sometimes they'll say, it's nothing, let's just get started on LTBI treatment. You know what, let's err on the side of active TB and start TB therapy now. Number 3, it's a skin test, let's get an IGRA. It's an x-ray, let's get a CAT scan. Some might get sputum for AFB Smear and culture and GeneXpert. And then for those who really are not sure next steps, they may just call public health and confer. So again, I planned a very simple vignette here to frame what often confronts us when we are looking to diagnose active tuberculosis. So of course we have guidance from CDC. I know you're aware of the core curriculum and the modules for each of these aspects that are being brought to you through the 101. And the 5 components recommended by our public health jurisdiction for diagnosing TB disease are medical history. I've alluded to some of that, but we'll dive deeper. Physical exam, you've heard some abnormality on this for this patient. Testing for TB infection. I'm going to propose that was a surprise to me when I first read it in this 5 steps to evaluation for active TB, and we're going to talk about that. Chest x-ray, well, of course, everybody seems to get a chest x-ray, if not more. And then the bacteriologic examinations. There's so much in this. I am highlighting some issues that I think cause people, as they're starting out in TB, to not speak the mother tongue and not understand fully the right way to go about this. So these are the recommended 5 components, and we'll talk about how they might play in to the simple vignette as described. First, we kick around a lot the notion of what's their TB risk. So here for you is a pearl. I believe we as TB experts, as TB practitioners in public health and clinical medicine should be clear when we're talking about who is at high risk. Are we talking about high risk for acquiring infection with M. tuberculosis, or are we talking about high risk for progressing from infection to TB disease? Those are actually different. There's some overlap, but I'd like to, encourage you to nuance your language, because not having a real intentional use of the phrase TB risk can lead to some confusion in next steps. So let me put this on the table and challenge you. High risk for exposure, for getting infected with M. tuberculosis, I think is pretty well known to you. Some of it's intuitive. People who have risk of being in an airspace where they could suck down a droplet nuclei, right? That you have to have somebody with TB in your presence. So this is context to a case. Having lived in an area where TB is common, visiting areas where TB is common, living or working in certain high-risk congregate settings like homeless shelters, low-income housing, places where people are abusing drugs or alcohol, and then healthcare workers who serve patients at risk for TB. Obviously, infants and children who are exposed to adults, that starts to overlap with the first bullet of context, but these are what CDC would like us to know with regards who is at high risk for infection, and this is all about the risk of TB contact. And the other way we talk about high risk for TB, we're talking about high risk of those who have infection progressing to active TB. So I hope that's very clear, but what you see in this slide are a lot of ways that people's immune systems may not control infection. Some of these might be a surprise to you. I'd certainly like you to be aware that the data continues to avalanche with regards those who are more recently infected with M. tuberculosis, that is within the last 2 years, are at a high risk of progressing, and then all the other immune compromising features. This is all about host factors for progression. But a person living with HIV, a young child, et cetera, is at no risk of progressing if they had no risk for infection in the first place. See previous slide. So this comes up a lot for us. So back to our case of the person referred for LTBI treatment, you do explore their risk for TB progression in the medical history. You already have a positive skin test. So in their history, you're asking these questions around the likelihood of recent infection through contact to a case and the various ways that people can be immunocompromised. And I want to make that very strong statement that I'm sure will be thematic throughout your education here. Do not treat LTBI until any symptoms that may reflect active TB are explained. That is this graphic from CDC adopted by a lot of different health departments. TB can have lots of different symptoms. We all know cough, hemoptysis, weight loss, night sweats. These are all the classics, but lots of other things can happen. Certainly, we know weakness and fatigue, loss of appetite, weight loss as a result. These can happen for pulmonary TB, but also extrapulmonary TB. And remember, symptoms of extrapulmonary TB are highly specific, dependent on where the TB outside of the lung is. Right. So if you've not heard this clearly enough, I'll bring up what's a pretty common graphic to show the dichotomous state, that is latent TB infection versus active TB disease. So, this acts as though a person is clearly in one camp or another. And the highlight for us relevant to this case and many cases we see is that you cannot call a person having latent TB infection as having any symptoms that are referable to that. So I see it all the time, and that's why I raise it. I hope some of you are rolling your eyes and going, well, of course, but yet it's something that comes up in our practice a lot, that we have a patient who's referred to us for treatment of LTBI, and they report night sweats, or they report losing some weight without meaning to, or what, and this puts us on a diagnostic trail. I'd like to go a little bit beyond the basics of this sort of dichotomous either or scenario of the state of having a TB bacteria in the body and bring up this super provocative and helpful, now getting a little bit old, graphic from Madhu Pai and McGill and his colleagues showing that what we know intuitively the TB is not actually that dichotomous. Infectious states are on a nonlinear disease continuum. People don't go on a dime from one to another, but there is what's called an increasingly studied subclinical TB disease on the way to active TB disease. There's also incipient TB, which is being referred to commonly also. And we just need to think about these and understand that sometimes the patient who's sitting before us for treatment of LTBI may be on that continuum, beginning to show mild symptoms, where the trajectory over weeks or months may show progression to active TB in the more classic way. So back to your what do you do? I'd like to suggest to you that I don't think the right thing to do is to hear this case and start LTBI therapy. So I know I've said that a couple of different ways now, but let me just put that X there and say, don't do that. I'd also say that it feels not right to me to use clinical judgment and just start TB therapy at this juncture. It's art, not science. I certainly would rather a clinician err on the side of treating active TB than treating latent TB. You see what I mean? But there is potentially unnecessary exposure to the patient. They are not critically ill, and you have some leisure to explore other ways to diagnose active TB before you might jump to using the safe and effective TB meds when you don't have to. So let's talk about the option number 3. Remember, this patient came to you with a skin test that was 11 millimeters. It's very, very common for clinicians to say, well, let's see what the AGRA shows. Now, there are reasons, some are justified and some are, I think, an unnecessary delay. When the skin test is at the borderline of positive, or the patient has had a recent BCG vaccine or other reasons, you might reach for an IGRA, but I often teach that the IGRAs are tests for latent TB infection, not active. So let's just talk a minute more about that. Let me challenge you in this regard. CDC does include within the 5 components for evaluating for TB disease, test for TB infection. So digging down a little bit deeper into the footnotes around that, I want to draw your attention to the fact that presumptive TB patients, such as the one I described to you, should be evaluated for TB disease regardless of their skin test or IGRA result. Clinicians should not wait for a TST or an IGRA result before starting the other TB diagnostic tests. If you're going to go to an IGRA, it should be given as this at the same time as other steps in diagnosis of TB disease. So this is a bit of an advanced concept, and I hope I haven't flummoxed you if you're just starting out in TB, but I'll say this a different way in case it'll be helpful. The IGRA and the skin test are studied as diagnostics for latent TB infection and are ancillary for the diagnosis of active TB. And I very much dislike it when a patient has their TB diagnosis delayed while clinicians add on an IGRA that gets sent out somewhere, and you begin to tack on 3, 4, 5 days of additional isolation for a presumptive TB patient while you wait for that result to come back. When data is extremely concurrent, here we have a meta-analysis that is aggregates of lots of different studies showing that the sensitivity of IGRAs among confirmed TB patients in low and middle income countries such as ours is imperfect. Probably if I asked you, if you have culture confirmed TB patients, what's the sensitivity? How often is the IGRA positive? I bet you would have guessed higher than the numbers shown here at 61 for T-spot and only 52% for quantiferon gold. So that's regardless of HIV positive or negative, and reflects the fact that when a person has active TB, their immune system has not held back the progression from latent to active TB, and using a test designed to detect immune response to latent TB infection is almost counterintuitive. This is already an immune failure to have active TB. So drawing on an IGRA, which depends on their immune reaction to TB, is falsely delaying and often insensitive. So with that, I would be bold and perhaps criticized to put a kind of in between X over ordering an IGRA. It could be used in concurrence with getting down to the more appropriate diagnostic tests. It's hard to intervene on this. Patients often come to us with the IGRA already done, already inserted into their diagnostic algorithm. But I challenge you to think about what I've said with regards to the utility in active TB. So in the options I've given you, I've also included a non-contrasted chest CT. And I imagine many of you thought that might be a good idea, particularly since it was a little hard to interpret the non-specific chest X-ray I showed you. And I want to talk a few minutes about radiography in general. First, let's talk about X-ray. Clearly, X-ray has had a hugely historic role in TB diagnosis. There's a slew of graphics you could choose from showing our love affair with X-rays for diagnosing TB in the United States, even when we had a lot more disease. So the kind of Easter seal shown on the left there, trying to encourage folks to get in for an X-ray. On the right, the mobile van kind of approach that is still used in places of high burden TB, not so much in the US now, but perhaps in high incidence settings for us, like city prisons and jails or what. So I think it's appropriate that if you are on a trajectory to become a TB expert, that you should understand how to read a chest X-ray with regards to TB. There is a awesome tool that I've highlighted below. This should be an active link, but is easy Googleable with the words as shown. So basic chest radiology for the TB clinician. It is a self-study deck, and I think it's done really well by UCSF, the Curry International TB Center. So if you want to improve your ability to read an X-ray, then this is for you. Within it, you will learn, of course, some of the pros, the cons, the limitations of chest X-ray. In pulmonary TB disease, the chest X-ray usually appears abnormal. So believe it or not, there's something to unpack in that short sentence. In extrapulmonary TB, the X-ray is likely not helpful at all, right? This extrapulmonary TB is a disease where it's outside of the lung. So you may see evidence of the initial infection by way of the Ghone complex. You may have heard of that. Little evidence of the initial battle, but otherwise, in extrapulmonary TB, the X-ray is normal. There is an intentional use of the word usually appears abnormal, because even in pulmonary TB, you can have a completely normal chest X-ray. So that's a problem. When it shows abnormalities consistent with active TB, these are often infiltrates. That refers to collections of fluid and cells, and bacteria, and lung tissue. And then very classically associated are cavities. These are holes, hollow spaces within the lung. It's shown in the graphic on the right from the CDC. So you have to squint to see what is an unexpected finding of a big hole. This one is pretty circular. So for the point of illustration, you can see it here. I like that they chose an X-ray from a patient who has a cavity in the lower lobes, because one of the other things I've heard and cringe at a bit is when an X-ray shows this, sometimes clinicians will say, yeah, but cavities for TB should be in the upper lobes. So this speaks to sensitivity and specificity of any of our findings in TB, yes, upper lobe cavities are classic for TB, but that doesn't mean that a lower lobe cavity is not TB as well. So making sure that you understand that. Nice when you see, but not exclusionary if you don't. So in the box below, up to 1/3 of pulmonary TB patients have non-classic chest x-rays, including completely normal, and only bacteriologic tests confirm TB. I do want to give you some hope that we're not in an age globally where we're holding up x-rays to the light and we're bringing every clinician together to try to do an interpretation of subtle findings, but that as happening in many areas of medicine, there is now AI that is helping us make TB diagnoses using plain chest x-rays. And I'll be very surprised that this isn't coming to the US as well. It is fully rolling out globally, but I believe that there may be some traction here in our own settings to increase sensitivity and specificity of using plain chest x-rays. In the words I've typed out here, chest x-ray does have a limited role in TB diagnosis. Globally, some of the difficulties in using it for this purpose are cost, access, maintaining equipment, having radiologists available to read them, and also having the techs available to do them, and then poor specificity. And this problem we have in several areas of TB old science, where depends on who you ask what the interpretation of the scan is. So digital chest x-rays create radiographs at very low cost, can be mobile, are in an increasingly widespread use. So many of us in TB in the US have had the extraordinary adventure of helping to diagnose TB in some of the islands in the Pacific that are US affiliated. And we actually brought these small digital x-ray machines onto these islands and went to villages to do digital chest x-rays that were then interpreted by a computer program. The World Health Organization fully endorses this. This is not a fringe idea, so I'm just drawing your attention to it. And in particular, it's kind of shocking. I'd be a little concerned if I was a radiologist right now that the computer can read for screening, just making a first pass, as well as a human reader. So pretty concerning. And as these algorithms improve, they may improve over the human eye. So that's one to watch. So back to what would you do on a case where you're not quite sure if the patient referred for LTBI really should be in a diagnostic algorithm, a TB diagnostic algorithm. I've already said IGRA is super plus minus. Chest x-ray will be done. It's hard to get a patient who has an abnormal chest x-ray not to have a chest CT, but here it is. It can have a role, but it does not likely have a role. So I think that the bulk of what we'll talk about now are the microbiologic approaches to diagnose TB, which are really the way to confirm. So with that, there are 5 aspects of the bacteriologic exam for TB diagnosis. This is, of course, CDC language. This is from the core curriculum, so I didn't make it up. Specimen collection, AFB smears, nucleic acid amplification test, which may be abbreviated NAT, N-A-A-T. You'll see it again. Specimen culture, and identifying the species. And then we need to know something about drug susceptibility testing if you're going to be an expert in TB going forward. So first, pausing on what may be the most important aspect of this approach to microbiologic diagnosis, yet one of the most neglected as well, and that is doing a good sputum sample specimen collection. great if the patient can spontaneously expectorate, that is, hawk up into a sterile container. Sometimes, a lot of times, the patient cannot do that. Either they don't quite know how to do it, or they have a dry cough and they're not producing sputum. So when they can't, then we talk about getting a hypertonic saline sputum induction or full-on bronchoscopy, where our pulmonary colleagues go down with the scope and grab a specimen. Hopefully, they can spontaneously expectorate, in which case that's a separate training for you to instruct and then coach the patient. So instructing, there are job aids that you can hand them. There are ways to talk them through rinsing their mouth with normal saline or water, sterile water, and then coaching them through the actual process. How often I see that sputum cup at the patient bedside, and sometimes there's 3 cups, 4 cups, because of course our inpatient nurses are beyond busy, and it's hard to stay with the patient and help them get that sputum specimen, but that's what's going to give us the best result, of course. So assuming they've been instructed, coached, and are able to, we should strive to have at least 3 sputum specimens examined in the ways that I'll describe. This comes up a lot. How, like, do you do them all one after another? No, you are in the best position if you can collect them over 8 to 24-hour intervals. So many of you have heard this kind of mantra of getting 1 a day times 3. You can do it more efficiently. Here the CDC endorses the possibility of using 8-hour intervals to collect. In the global arena, we do morning spot or morning spot morning, that definitely emphasis on trying to get an early morning specimen, because these traditionally show higher yield on the studies that are then put forward for TB diagnosis. So this can be cumbersome. I'm going to come back to this in a few minutes, but I do want you to know what the standard is. So at least 3 specimens collected in 8 to 24-hour intervals with at least 1 early morning specimen. So what are we going to do with those specimens? We are certainly going to do AFB smears. In the category of AFB smears, I think it's worthwhile noting there are 3 different types. There are 3 different approaches to this. There are the Kenyon and Zeal-Nielsen stains that are used under light microscopy. So using a really traditional microscope and this ancient approach, more than 100 years, to stain the bacteria, as shown in the upper graphic. Those are the infamous red snappers. And assuming you can see my cursor, you see these long red stained organisms, which are the mycobacteria. It's been a great advance for our microbiologists to have the fluorochrome stain, because it can be viewed under fluorescence microscopy. So that means that the microbiologist doesn't have to look under a 100 magnification, but can look at higher and see these really bright spots that are more easily scanned, and it goes a lot faster and has a higher sensitivity than the traditional light microscope using the, not surprisingly, more than 100-year-old technique of staining. So pay attention to whether your patient's specimen has been evaluated using a Kenyon or Zeal-Nielsen or a fluorescence microscopic approach, which will have greater sensitivity. There's other language within AFB smears that I hear my own public health nurses looking to understand. So I'm going to be really directive here and talk about direct smears. So what this means is you take that expectorated sputum and you do the microscopy on it directly. So, when you think about it, that name seems pretty intuitive and is kind of going to be easy to remember. But what will be helpful for you is understanding the difference between that and the concentrated smear. So that is the smear done by either approach as above, that is, any of the stains applied after that specimen the patient has given you has undergone some processing, including centrifugation, meaning it gets all spun down and they take the most concentrated aspect of that sputum and put it on a slide. So the concentrated smear is more sensitive than the direct smear, but it compromises the yield of the culture because that processing kills about 30% of mycobacteria along the way. So you have a pro and a con to looking at concentrated smears, higher sensitivity of the smear, but lower sensitivity of the culture. An indirect smear means that the culture is growing and the microbiologist takes a specimen of that to smear and stain to look to see what's growing. So note those differences. A direct smear is on the sputum itself. The indirect smear is taken from the culture. A concentrated smear is taken along the way of culture processing. All right, so probably more than you wanted to know about smears, but as I said, I hear these kinds of confusions all the time, the difference between direct and indirect and concentrated. You know that the smears are reported as negative, 1+, 2+, 3+, or 4+. This graphic shows you what the microbiologists operate under with regards to calling it, depending on what degree of magnification they're looking at, 200, 250, 400, 450, how many organisms they're seeing. Here's the red snappers again on a single field. So do you see 1 to 2 on 30 fields? Do you see 1 to 9 on 10 fields? Do you see 1 to 9 on 1 field, which is closer to what you see in the example graphic, and etc. So note that these are tenfold differences. I know there's a lot of numbers on this, but for example, as I've written below, a 4+ positive smear has 10 times as many AFB organisms than a 3+ positive smear. These are substantial differences. So this can be useful when you're monitoring your patient on TB treatment, when you see they go from 4+, 3+, 2+, to 1+, etc. That this is a lot of bacteria reflected in very small number differences. So I draw your attention to that. These are international standards, and they are not randomly assigned by the microbiologist, but rather counted very systematically. I'm going to wrap up what I said about pros and cons of microscopy. Certainly variable sensitivity. Only maybe say 50% for culture-proven pulmonary TB. That is, of course, you can have smear-negative active pulmonary TB. And the chance that the smear is positive is less in persons who have miliary TB, advanced HIV TB, or in children. Remember, the limit of detection varies by what stain is done, whether it's the ZN, Zeal-Nielsen, or the fluorescent stain. And then the degree of smear positivity correlates with disease severity and also infectiousness. When a smear is positive, you know it's not specific to the tuberculosis complex species. That is, it could be a different kind of mycobacteria. It could even be nocardia, or a different kind of organism altogether. It is inexpensive and has a quick turnaround time and has a great deal of value for providing first evidence of TB in some cases. Sometimes it's a surprise. And it can be used to guide therapy through quantification, as I've alluded, as somebody progresses through 4+ down to smear negative. So let's turn our attention to culture methods. These could be on solid media, including Middlebrook or Lowenstein-Jensen. Solid culture media can take up to 8 weeks to grow. On average, it's a lot less than that, but we always counsel our patients that the culture is not considered final negative for upwards of 8 weeks. It certainly has an advantage where the laboratorian then has a colony, has a little, grouping of bacteria that gives them a suggestion of the species right away. They look at the colonies and can say if there's color, whether it looks like Mycobacterium kansasi or one of the non-tuberculous mycobacteria. The other way to culture, which is inevitably available to you through your whatever lab you're using, is liquid culture or broth culture, some of which are highly automated. Most commonly used in the US is the Bactec Midget 960 system. It's not the only one. A lot of times people hear about the BACT method, but often it's Midget. And there's more rapid recovery than solid media. On average, it's between 7 and 21 days for culture confirmed TB. So that's a substantial advantage to using the liquid culture media systems. But the downside is that these are rich media, really appealing to whatever's contaminating that sputum in terms of normal oral flora or other things, and it's much more likely to be contaminated. Upwards of 10% of midget cultures can be contaminated in some settings. So then you don't have any data coming back to the patient in some situations of using broth. And therefore, current US recommendations are to use solid end broth to increase sensitivity, meaning broth more sensitive, but also more likely to be contaminated. So good thing you have a solid media in backup. So that's the way all of our labs proceed according to these guidelines. So you get more than one culture result, more than one culture type back, because this is US guideline. I'm not exactly sure why in infectious disease we always want to call out the gold standard, and for a very long time, culture has been called the gold standard in TB. Beautiful culture isolate there on the right. These are on solid media, the wrinkled kind of brain looking colony. There's very little else that looks like this but TB. So, this can be a slam dunk for a microbiologist to say, we're growing what looks like TB, but this is an idealized version, and sometimes it's hard. The culture colonies are available then for identification, speciation, drug susceptibility testing, and these are key. Culture also has the advantage of being able to be performed on any sample. You could take a lymph node biopsy, CSF, a bone biopsy, et cetera. Anything can be cultured for TB. And it's certainly more sensitive and specific than your AFB smear, which is that quick look that quantifies the number of bacteria present. When you get a colony that isn't absolutely classic, like the one I've just shown, the laboratory will go through these kinds of gyrations to tell you what the mycobacterial species is. Growth characteristics, conventional biochemical tests, fancy high pressure liquid chromatography, I think is the P, of the cell wall to identify what kind of species it is. There are commercial genetic probes. I think AccuProbe is now off the market. Somebody can Google if that, or chat if that's not true. MALDI-TOF, which is now coming into everybody's laboratories, pretty cool, can identify multiple of the most common mycobacteria in the US and can be very fast. And then there's polymerase chain reaction, genetic sequencing, and others that we'll talk about in some more details. In terms of caveats on our so-called gold standard of TB diagnostic maneuvers, a negative culture does not exclude infectious TB. So that's pretty annoying. You sometimes are faced with a series of negative cultures and people still are not sure whether it's TB or not, because maybe you had a bad specimen, maybe it was a tiny specimen, maybe it was contaminated, and the microbiologist couldn't read it. Maybe there were only dead organisms present if you're using it for monitoring somebody on treatment. And then a positive culture doesn't necessarily mean it's MTB in terms of the potential of cross-contamination in the laboratory. And now this doesn't happen so much given our good methods in labs, but it still should be thought of when the lab comes back with a diagnosis of TB and it doesn't make any sense. again, this is a patient at no risk of TB infection and no risk of TB progression, and you are, you know that the patient has no cardia, something like that, and then they tell you the culture is positive. You just need to encourage clinical acumen and think about whether it makes sense and whether instead there may be cross-contamination in the laboratory. Cultures are important to guide management, colony counts, looking for sputum conversion, usually at 2 months. And then knowing that if you have a low rate, if you have a slow conversion to culture negative, this may mean something's going wrong in the course of treatment. So let's talk expert MTB-RIF, the Cepheid test. So lots of words around this. A lot of times people just call it expert. And I imagine if you're anywhere in the continuum of learning about TB, you're starting to hear about expert spelled that way, not EXPERT. That can flummox some folks early on when they're trying to order the test. When they order expert with an E, it doesn't go through, that kind of thing. It was developed by Cepheid with a great deal of funding and pressure from the public-private partnership in Geneva, the Foundation for Innovative New Diagnostics, and it has been transformative to global TB control. So I want to not sound as though I'm understating that and offer to you just how different this is than culture. It is automated, real-time PCR. It's quite simple. And the module, as you see it here, is multi-disease. So let me unpack that a little bit, shall I? Automated meaning the laboratorian has to squirt the sputum specimen into that cartridge. So it's pretty darn easy. They just put it in there like it's the Keurig coffee machine, and then off it goes. It's about 90 to 100 minutes to run this PCR, and it is highly sensitive, thought to be equivalent to culture. I'm going to talk about that in a moment. And also gives what's so important in the global arena, especially where there is more drug resistance. This gives the first signal for rifampin resistance, abbreviated below in the, I don't know, 5th bullet or something, RR. That's become a global parlance for rifampin resistance, which predicts multi-drug resistance, which includes also isoniazid resistance. So an incredibly powerful tool that moves us from 6 weeks, 8 weeks, 12 weeks to get susceptibility testing done through phenotypic culture methods to 90 minutes using GeneXpert. So there's a sub-bullet there that's for those of you who are ready for a little bit more advanced notion, but the sensitivity for rifampin resistance is compromised in some parts of the world because of unique genetic features of the bacteria that circulate there. And that means in the US, for people who come from those parts of the world, this has been corrected in the next generation of expert that I'll allude to in a moment. So in the US, this is FDA approved only for respiratory secretions. Note it also has a limitation of not being appropriate for use for TB treatment monitoring. It's only for diagnosis because PCR can detect dead bacteria's genetic material floating around as well. It does not replace culture. As in the previous slide, there are advantages to doing culture that you don't get with experts, such as culture conversion timing, knowing something's going wrong with treatment, and also a full drug susceptibility panel so that you know what's going on with ethambutol and amikacin and some of the other TB active drugs. So here's a slide included for your interest on the technical aspects. And I know some of you may be interested in that if you're more on the lab side, but there's one proprietary agent that gets added to the sputum, and then it gets squirted into the cartridge, that gets put into the machine, and then all the fancy stuff happens behind the closed door to pop out at last the red and the green. MTB detected, RIF resistance detected or not detected. In this example, not detected. So in lots of presentations I hear around tuberculosis, I hear, and the GeneXpert was positive. So if you'd like to move toward expert language, and I mean EXPERT, the way to report on a GeneXpert result is to say MTB detected, RIF resistance not detected, or whatever the result is. So it's those two parts that anyone managing a TB case wants to know. So now I hesitate a little bit to show you that Expert has gone into a next generation that is referred to as Ultra. So I would challenge you to consider that this is the best gold standard in TB diagnosis that we currently have. The Expert MTB RIF Ultra increases the sensitivity over regular Expert MTB RIF by incorporating 2 targets for the PCR. It's probably 1 log improvement in the lower limit of detection compared to the first generation of Expert. And accuracy studies consistently show Ultra is more sensitive than MTB RIF first generation in the place we really want it, which is possibacillary pulmonary disease like smear negative, as is more common in persons living with HIV, in children, in extra pulmonary specimens. And then as a result of all of this consistent data, some of the references shown in Cochrane reviews, that's how much data we have proving all this underneath the cartridge, as you see, if you want to dig into it a little bit more deeply. As a result, WHO endorsed the Ultra for global use in 2017, and it is being used elsewhere in the world. In the US, we continue, continue to wait for it. I think that's sad. I won't editorialize more on it as you're at the basics, but when we find our voice for advocacy in the space of tuberculosis control and management, I hope that you'll add your voice to the fact that it's pretty outrageous that since 2017, the world has been using this better device, and we're still in the US using the old MTB RIF. So let me leave that behind with some additional data challenging the notion of gold standard. So I've already alluded to the fact that Expert in the first generation has been called equivalent in terms of sensitivity for culture, sensitivity to culture. And now we know likely that Ultra is even more sensitive than culture. So in the initial trial that compared Ultra to culture, a very funny thing happened, which was the specificity of Ultra looked like it was worse than culture. That is, it looked like there were some false positive results on Ultra, and these have been clarified to be revealed as actually false negative results on culture and true positive on Ultra. So you can see how if you called the gold standard culture, it could result in a bias against Ultra. And I think that we all appreciate now Ultra works even better than culture. And yet we are not looking to replace culture methods in the United States because of those advantages for drug susceptibility testing and genotyping. I didn't mention that as an advantage of culture, but genotyping is when we look closely at the fingerprint of the bacteria to see whether it is linked to other cases in our jurisdiction, for example, suggesting a way to control outbreak. So back to the case of maybe an LTBI patient, but that you identify symptoms. We are totally supportive of getting sputum for AFB smear, culture, and GeneXpert. That's the way to proceed in a case as described. Everything else above is kind of a slowdown to a patient who may be forced to be on isolation while you figure it out. And so I definitely want people to put Expert first at least put sputum collection first, and then ideally it goes to expert and smear and culture. I want to just take a moment on that last bullet. Call public health is always the right answer when you're not sure what to do with a TB suspect, a presumptive TB case in the current parlance. And not only does it help you, it is required in every state jurisdiction to report presumptive TB, which means suspected, not confirmed TB, to your public health jurisdiction. So just bear that in mind. These are the two most right answers in the vignette as shown. It's 11 o'clock now. I'm going to pause and see if there are any questions before I go on to some more advanced diagnostic concepts. Are you seeing any questions in the chat? Any concerns?
Yeah, I don't see any questions in the chat, Dr. Talbot.
Okay.
If
We'll
anybody
plow
wants to
on.
unmute, yep.
Absolutely. And I am fine if you want to contradict me, if you want to add something, if you want to question something, please feel free to do so. I think people learn really well when they hear others rather than me droning on too long. But in the absence of such, I'll go on to
I'm sorry, Dr. Talbot. I see somebody who's unmuted. Maria Bansfield, do you have anything to add or any questions?
Oh, no. I accidentally unmuted. No, I don't
okay.
have any question. I'm sorry.
No problem. No worries. No worries.
No, thank you, Mary, for adding your voice, because as I said, I feel like I'm droning on and I don't want to do that to you. I'm sure you're busy and tired, and let's make this relevant to you. So I'm going to go on to a next case, which feels really familiar to me. This is the kind of thing I get consulted on all the time. So how about this? 71-year-old US-born man, months of coughing, maybe some night sweats and fever. The coughing's getting worse, and now there's blood in the sputum. And he's also really worried because he's inadvertently losing weight. He's worried because he knows he has cancer risk. He has a 50-pack-year history of smoking. He's been said to have in his medical history COPD, but he's not on any specific treatments for that. Somebody didn't like hemoptysis, weight loss, and night sweats, so they did a skin test, and it was his first in his lifetime, and it was 11 millimeters. Uh-oh. So your TB infection risk shows no residence in high burden country, no contact to a TB case, wasn't in prison or homeless either as an employee or a resident, no toxic exposures, which could incur risk to progression. And more detail in his x-ray, multiple small nodules are called out, and also scar tissue fibrosis. So lots of times pulmonary nodules are seen and cause us to scratch our heads regarding what could this be. Non-infectious malignancy tops it. There's lots of different malignancies, particularly smoking related. There can be rheumatologic and autoimmune disease like Wegener's that can show nodules, arterial venous malformations, pneumoconiosis from working in a mine, silicosis from the same. And then in my arena, infectious nodules can be bacterial. We see this, unfortunately, commonly in substance use disordered patients who have tricuspid valve endocarditis and show nodules or even abscesses. These are septic emboli. Fungi can do this. And remember, histo, blasto, and cocci are increasing given climate change, and the extent of these diseases is expanding. So good to get it in your armamentarium of differential. And then what we're here about today is concern for TB, or the non-tuberculous mycobacteria, of which there are more than 200 species. You heard this talk, you get sputum, and the AFB smear is, positive. How do you distinguish non-tuberculous mycobacteria from TB? This is a very common question, and there's actually a really simple answer. So I'd like to challenge you with the current kind of options I see. Sometimes people say, can't we just treat them for the most common NTM in the country, which is M. avium? Let's see if those nodules get better. That's called a diagnostic trial. Should we just follow up the skin test with an IGRA? It's only 11 millimeters. Maybe it's a false positive. You know how I feel about that. Should we await the sputum culture? Remember, it could be out to 8 weeks. Or, I think you see where this is heading, get sputum for expert. So, absolutely. Can I highlight this in any way to you that this is incredibly helpful to end this hand-wringing over whether it's TB or NTM? So here we have in national guidelines from ATS, CDC, and IDSA that getting a nucleic acid amplification test, a NAT, in the US, referring to expert, this refers to expert, will solve this problem. So look at the graphic below. In this case, his AFB smear was positive. If you get an expert and it is positive, then you know you have tuberculosis. So you see we're in this box. TB is diagnosed. You're waiting now for culture and to get the drug susceptibility testing, but you might consider empiric treatment, isolation, contact investigation, all of this. So now you are squarely in a diagnosis. Suppose the sputum is smear positive as this patient and the expert is negative. Check it out. TB is unlikely. In some cases, if you don't think you got a good specimen or your risk is really high for TB, you might get a second expert. But in general, this diagnoses non-tuberculous mycobacteria, an AFB smear positive, expert negative specimen is NTM. So that is the answer that would save people and patients a lot of concern. All right, I got another little vignette for you, something that I see come up a lot. So an inpatient twist. So a 67-year-old, otherwise healthy woman, hospitalized with concussion. She tripped over her little dog in the kitchen kind of thing. No known TB contact, no risk for infection. But they get an x-ray for unclear reasons, and it incidentally shows some tree and bud nodular opacities. So of course the intern goes back and says, hey, your x-rays are abnormal, anything going on with your respiratory tract? And she does report frequent colds, she's had a lot of bronchitis, she's had a lot of cough this year. So, of course, the appropriate move without any further information is to consider that this might be TB and the patient is moved to airborne infection isolation. So not convenient for the patient, not ideal for care. What do you do to get her out of airborne infection isolation in your hospital? I think that you have some options. If you're savvy, confident, can follow this, you recognize this patient really, like never left their farm in northern Vermont, never met a foreign-born person, never worked in a homeless, you have no risk for infection. Call it low suspicion and just discontinue AII. I don't see many clinicians willing to do that. You could do TST or IGRA, but note what I've told you before about these not being diagnostics for active TB and potentially slowing down, making it longer in isolation rather than shorter. We all have used very regularly 3 negative sputum AFB smears 8 to 24 hours apart, at least one early morning, in order to get a patient off of isolation in their diagnostic algorithm. Or I would propose to you require 1 to 2 negative expert tests. That's going to be the answer because there's massive problems with that smear strategy we've been using for decades. When you look back at all the people who have had that algorithm applied, such as the patient described, it takes on average 5 to 7 days on airborne infection isolation to accomplish this. It's expensive. You use up an AII room. And meta-analysis show this is not good for the patient. There are more non-infectious adverse events like blood clot, poorly controlled diabetes, and et cetera. They have patients incur risk of depression and anxiety on isolation, and there's certainly decreased patient satisfaction with care as they're living with this anxiety of having a severe illness. And in the United States, most people in AII don't have TB on high order. So in this huge study, it showed us how powerful expert is for diagnosis of TB. But when you look at it a different way, as a rule-out test, one expert assay predicted AFB negative, culture negative status with a negative predictive value of 99.7%. If you do 2 experts on a patient like this woman with a concussion, the negative predictive value goes to an unheard of 100%. This is approved in your algorithm. So take this opportunity to look at the data and follow the guidelines, that if you want to get a patient who for you is a TB, a presumptive TB, what we used to call a TB suspect, use an expert to get them out of isolation. So this is written up by NTCA, APHL, CDC, and there's lots of guidelines on how to use this, but the time is now to recognize the power of expert, not only for diagnosis, but for ruling out TB as well. I can see I have only 5 minutes, so I have one more case, but I might just pause to make sure the bread and butter is...
Yeah, there's one question by Wayne Griffin in the chat. It says, with the expert, what is the frequency of calibrations?
Yeah, thank you. Thank you for tempering my enthusiasm slightly. This is not a device that can sit on the lab countertop without some kind of care. And currently, the modules for calibration are annual. So in the global setting, that costs money. It can be hard to reach the machines and et cetera. So there's been a lot of work on doing it in a remote way to calibrate the machine. But for our own laboratories in the US, it's fairly, I think, trivial to recalibrate and do quality assurance on the performance of the machine, given that they're not always used very often, in fact. So hope that answers your question. In my next case, I simply am going to shoot to the upshot here. This is an MDR, multi-drug resistant TB suspect by virtue of the vignette as shown. And in this picture, 2 very favored actors for me, Patrick Stewart and Ian McKellen, are in a scene from Samuel Beckett's Waiting for Godot, the play, where these 2 guys just stand around endlessly waiting. And the analogy here is we endlessly wait, it seems, for drug resistance testing on a TB patient who's confirmed. So this is kind of that next step. First, you use an expert and get a signal for rifampin resistance, but you do need that phenotypic testing through the culture that you've acquired. And in summary, this slide shows risk factors for MDR-TB when you should be reaching for the advanced diagnostics for drug-resistant TB. We can do it through growth-based testing, as described in this slide, but it takes a long time. So the guidelines from CDC are included here as to when you have to do them, when you have to come up with the final susceptibility testing. And what I draw your attention to is there are probes for genes known to be associated with drug resistance. You can get these through your TB program. Not all mutations are identified. So, again, looking in this row, sensitivity and specificity is going to vary on that basis, meaning if there's a mutation that confers resistance to ethambutol that hasn't been incorporated in this method using a different kind of probe, then you're not going to detect that. So we get some funny reports back sometimes that require some expert reading about mutation not detected. It's frustrating because it doesn't say not resistant, but the nuance here is we don't know all of the different ways that this bacteria becomes resistant. So we have a tempered report that comes back when you order your genotypic methods. In this case, this patient did have their specimen sent for the molecular detection of drug resistance. It's also very fast. It's been very helpful to us. And in this case, the patient was MDR fully drug resistant to include also second-line drugs and was a great challenge. In my concluding slide, this is a great resource, not only the core curriculum, but the, as alluded, ATS, CDC, IDSA practice guidelines that include recommendations around smear microscopy, culture, this molecular susceptibility testing. There's a nod to the ways to approach TB diagnosis in children, how to get a good sputum induction, when to do a bronchoscopy. and then how to get good extrapulmonary specimens. We're out of time, but I hope at least you'll think about TB and feel more confident in your approach to diagnosis. So with that, I conclude, see if there's any final comments or questions.
Thank you so much. And I'm going to share the link to the resource that you just put it in your slides as well for people to access it.
Sounds good. Let me see.
I don't see any questions.
Oh. You're a quiet group. I hope it was clear, and I hope we'll cross paths again as needed. Yeah.
Yeah, thank you so much. And I'll send you all the evaluation for today. And if you have any questions that you thought about, definitely share them with me, and I can certainly ask Dr. Talbot to answer any questions that you may have.
Happy to. All right. Good day, all.
Well,
Thank you.
thanks, everybody. Have a great weekend. Bye.